Thank you to all our guest lecturers and moderators from the previous session. Now we shall move to the next session on women in spinal surgery, which will be moderated by Dr. Shraddha Maheshwari from Mumbai and Dr. Suchanda Bhattacharya from Nizam's Institute of Medical Sciences, Hyderabad.
I had to work in system.
Good afternoon, everyone. Am I audible? Hello.
Yes, ma'am, you are audible. Please go ahead, ma'am.
So, do we have Shraddha here? No? I don't see her.
Ma'am, she will be joining soon. You can start the session, ma'am. We are connecting to her. We are trying to connect to her.
Okay, fine. So, I mean, it's good afternoon here and maybe good evening or good morning elsewhere. So, I start this session, the very special session on women in spinal surgery, and I am really thankful to the organizers of NSSA, led by Professor P.K. Sahu, sir. I can see him sitting in the technical room. Good afternoon, sir. And the rest of the executive members, the president, this one of all the people in the Spinal Association Society of India to give this platform to encourage the women to speak about spinal surgery. Because I think women are still quite a few in this field of neurosurgery, and this is definitely a boosting platform for the women to speak. My co-chair will be joining soon. We have international speakers as well here. And since I am the opening batsman, I think you can cast my presentation. And then we will go to Dr. Craig Drummond from Australia and the rest of the speakers who are yet to join now. So, good afternoon once again, and I start my presentation on pediatric AADs, and I am thankful to my teachers, my colleagues, my residents, because every day is a learning when you operate, and then some residents come up with brilliant ideas, and of course, it's a learning every day. So pediatric AAD, the exact incidence, if you look into the literature, you will not find it. Because I think it is not so common like the adult AADs. Nevertheless, we go on doing it quite frequently in most of the high volume centers. And but we know that 6.1% of pediatric AADs are due to trauma. The other causes remain congenital as well as inflammation. And what does it do? It results in instability between the atlas and axis, and the clinical features, they present with limitation in neck movement, neck pain, or severe spinal cord compression. So what are the problems with pediatric spine? In fact, the differences from adult spine, they have immature ossification, they have small size of bones of children, anatomic variations associated with syndromic cervical abnormalities, unintentional durotomies can happen because the dura are relatively thin here, and post-operative superficial posterior wound sepsis is relatively more common in children, and chest infection can occur more common in children compared to adults. So the complications could be there because of hardware, like infection, osteomyelitis, leading to occipital bursitis is quite thin in these children. Rigid instrumentation, mobilization, incomplete fusion, loss of correction, neurological impairment, and insufficient spine range of movement for everyday activities, and a nagging cervical pain, which the patients come and complains when there is a instrumentation. So now this is a variety which is predominantly seen in children, the AARF, and they present with the classical cock-robin, sometimes classical, sometimes non-classical. They have pain and stiffness where the chin is tilted on one side and there's a torticollis on the other side. And this happens due to the spread of inflammation from anastomate, lymphatic, and venous channels of the pharynx together with post-inflammatory ligament loosening. So before actually the inflammation settles down, there is already fibrosis in the capsular joint, and this leads to a fixed deformity when we call it an ARFD. So why they are predominant in children? Because they have a shallower and more horizontally oriented joint surfaces in AADs, atlantoaxial joint, the relative elasticity of the ligaments, the incompletely developed neck muscles, and a relatively larger head. So there are various types as given by Fielding and Hawkins, and type 1 and 2 are docile and can be managed conservatively with the collar, and and type 3 where the AAD is more than 5 mm and TAL is affected, and type 4 is the rarest one where the odontoid is absent and there is a retrolisthesis of the atlas. So these are the pictorial depiction. You can see this is retrolisthesis. Then, so these are the management protocol for this. You do an investigation with a radiograph or CT, and you can try with the distraction treatment, or otherwise you have to do either reducible or irreducible. You have to do a release, transoral release, and a posterior reduction in C1-C2 fusion. What are the management goals in pediatric AD? Reducing fracture in case of trauma, relieving spinal compression, reconstructing the spinal stability, and correcting cervical spine alignment. Optimal approach and technique is, however, customized according to the patient. So this was in 1980s. It was very, very simple. It was irreducible. Ventral, there is a problem. Encroachment, do a transoral release, and then posterior fusion, and if it is only a dorsal, then of course a posterior fixation. But in 2015, now with the advance of MRI techniques and the advance of technologies, this has been further improvised by Dr. Menezes' group in 2015. And now we have this MRI, and then when you can see it's reducible, if it is acute, you go for immobilization and orthosis. If it is chronic, unstable, do a posterior fixation. If it is no compression, you can just follow up. And if it is irreducible, you again try a new manipulation under GA, and then if it is still irreducible, then you do a fixation. If it is a ventrolateral, you can do a transnasal, now endoscopic, or an oropharynx like microscopic, and then do a fusion. So this is the management protocol for this case, which is followed in most of the centers. So they are the historical vignettes that contributed to the evolution of surgeries in this region. And these are the various demonstration of what they had done. And the external immobilization halo is not now commonly used, but at one point of time that was the most commonly used. So now the most popularly used techniques is Holmes and Goyle's technique, where you do a pedicular rod and screw fixation. The rest are not done. And then there are various improvisation of the techniques, like C1 posterior arch cross screwing or the translaminar screws in situ. So I'll just go through a few cases. Then this was a classical when we used to do earlier. She came with the typical neck pain, hypertonia, and a C1 C2 sublaminar wiring was done. But in 2010, she came back again with a broken wire, which is a common complication for wire. Hence, they are not now used. I think it was almost they're obsolete, like very less it is used, except for very young children. And then we did a rigid fixation of occipital C2, and the patient is going fine. This was also another technique which was used in the yesteryears, like putting a rib graft and wiring, but then they are also not used now. This was also in the early 2000s. Then came the transarticular screws, but then they also did not become very popular because of the complication was slightly more, and also the hypoglossal nerve is at risk when this technique is used, and the vertebral artery injury rate was almost 4% in this particular technique. But however, I would like to show this case because this is not a pediatric. It was a 22-year-old boy where we did a posterior transarticular fixation. Patient is doing fine. 6 years follow-up now, but now we are not doing anymore. Then comes the C1, C2 posterior fixation, which has actually stood the test of time, and I think most of the centers has adopted it and doing it on a routine basis now. And these are the original papers where it was described. Subsequently, there are a lot of papers from Dr. Goyle's group on this particular subject. And say this is what you do. You take a lateral one, you put a lateral mass screw in C1 and a C2 pedicle, or if not pedicle, a bar screw. And this is how you do. This is the direction of how you do. And this is one of the video where we actually do these sessions. This is a 3D model of a cranial junction in the morning. And here you can see this atlas is rotated. It's the spinal process of C2. And we have to put a C1, C2 screws. So how it helps us is to build a memory the day before when you practice. So you see this is the entry point of C1, so you have to drill this part out. At least 1/3 if you drill, then the screw head sits properly, and then you drill cranially and medially. So when you do that, you can see that you will reach the middle of this lateral mass. And for C2, it is described as 2 to 3 mm above and lateral to this joint, but you can either put it here or then you can follow this line, the minor line, and you can here also cranially and it's that medially to go into the pedicle, the vertebral artery foramens area. So this helps you tremendously in gaining confidence and doing complicated things once you fix it. This is a 3D. So we do this practice session whenever we have a complicated case with a 3D bone model, so that the resident is in tune, and as well as we have a memory of what we will be doing in the theater. It becomes easier and you are more confident. So this was the initial paper where they had a complicated, but now this has also come down. And this is, of course, this do happen at some times with temporary C2 neuralgia. We come across patient complaining of this, but they settle down in due course of time. So there was a prospective single-blinded bicentric study between Hyderabad KIPS Hospital and SGPGI Lucknow. Though they did not find this statistical significance, but functional outcome was better when they preserved the C2 ganglion while operating. This is another case of a high compressive cervical myelopathy with AAD. You can see that, and we did a C1, C2 posterior classical fixation. Patient is doing fine. This is another case where she had again came with the similar complaints, and there was an BI along with assimilation of the atlas. And here we could not actually navigate. So on cable we decided we go with the plan. Sometimes you cannot navigate. So we did a translaminar C2 screws and an occipital fixation. So this also patient is doing quite well. So, there are various alternatives which you need to know. Now, this is one case where we landed up in a complication. You can see this is the posterior arch is deficient on this side, and there are this vertebral artery branches coming in the joint space. However, we attempted the C1, C2. We could negotiate it, but what happened while doing the surgery, the spacer on this side actually slipped and went out, and we could not retrieve it back. So we were very scared. That was one of my initial cases, and we just closed this after fixation. But later we came in again and we did it. And now after 5 years of follow-up, he's doing quite well. But his this spacer is lying in that particular space. So we do have all these problems on and off. And this was one case where we never knew, but we had probably a CSF, a dural puncture, and there was a meningitis, and then this was again, we did a C1, C2 fixation, and then you can see there was a pneumocapillus which developed, but subsequently healed with antibiotics. So this was one of the case. Our complication I wanted to show came at 16 years of age. We did a fixation C2 and occiput and C3 because we could not navigate the C1, but then he remained to have a stunted growth. So all these problems do happen in the children, and that's why I highlighted only the complication one slide and not the good ones. And donor site morbidity was there significantly, and hence they are now of course they are not used. The best graft is the occipital graft, as it is said these days, or you can take from the spinous process, but then the element is less in case of the spinous process. And so they are also not very commonly used these days. Unilateral instrumentation sometimes becomes a requirement when there is an injury on one side, or you are unable to navigate on one side, and then these are the advantages and the disadvantages. There's a pull-out maybe more in case of an unilateral because children have larger head compared to the adults, and we need to keep this in mind. So how do you avoid the complications? So as I demonstrated, like, we take a 3D model, and this helps because it helps you in surgical planning, it helps you in taking a video consent from the parents, and it helps you in actually practicing and becoming an education tool for the medical students and the residents. So odontoidectomy, though many people advocate that odontoidectomy is almost obsolete, but still I do not think so that is the case, because many times this only posterior fusion, they come back with symptoms and they continue to have symptoms at that time. Sometimes the ventral compression does not release. So we have to do, many times we have done after a posterior fixation, we went in anteriorly and did anterior release either through a nasal or an oral approach. Nasal, if it is at the nasal level, we do endoscopic, and oral, we do a traditional microscopic. The complications are more or less same. In endoscopy, you may have an additional nasal thrusting in children, which can be very discomforting. Growth restriction, is this really an issue? Future spinal maturation potential, and all these things are talked about, but the bulk of the cases are after 8 years, around 8 to 12 years you get, and the ossification it becomes like an adult by 8 to 10 years. So this is actually not a very big problem. But yes, instrumentation in less than 3 years is definitely a problem, because we do not have screws less than 3.5 mm. So what is the future? If we can think and devise an implant which are absorbable and appropriate for occipitocervical fusion in the young, ultimately they will provide immediate rigidity and the fusion is occurred and then resolve. But I don't think so. We have anything in our hand of that still now. And our small experience at NIMS, this is not only my experience, but my department's experience with 97 other colleagues are involved with this. We have 96 cases of pediatric CV junction fixation. Now, if you see, if I presented in 3 slabs, and if you see at this point of time, before 2010, we had around 80 wiring cases. But by 2021, in the last layer, from 15 to 21, we don't have any wiring anymore. It's just a C1, C2 fixation, mostly. So this is how the evolution is happening in an institution, in government institutions in India like this. I think it will be the same picture in more or less all the places. Complications are sporadically. We do have complications. We also had a mortality in the last leg as well. And these were the other complications we had over this more than 10 years of collection of cases. And in conclusion, I would like to say that internal rigid fixation is the best in the same group and can be done. Judiciously determining the surgical procedure by studying the CT scan and rehearsing on customized 3D model gives good result. Learning curve do exist for CV junction instrumentation, and less than 2 years difficult for fixation with screws. A temporary fixation can be done and then later converted into a permanent fixation. Thank you. Happy to take any questions.
Thank you, Dr. Suchanda. I'm sorry I was a little late for the session because of some internet issues. I think it was a very comprehensive and lucid presentation on C1, C2, especially in pediatrics, where there are a lot of questions that everybody has in their mind. Ma'am, have you tried, we have cranial implants which are absorbable. Have you tried or thought of putting those in pediatric C1, C2, or in children who are less than, a certain age?
Because the screws are very small for the cranial one, the length will not suffice in the CV junction. So until we get a long length screws, I am not aware, I have not used it. That was once we had a discussion, and that was the reason they told it. I don't know if you have an experience on that. I don't have that.
Okay. Are there any other questions from the house who would want to talk about this or want to know more about pediatric C1, C2? Okay, I don't see any more questions coming in. Are there any questions from the delegates, Saurabh?